As we know, vascular endothelial growth factor, or VEGF, is a known therapeutic target in metastatic renal cell carcinoma. There's been increasing evidence that ASIs, or angiotensin system inhibitors, can actually modulate the VEGF pathway. ASIs are very commonly used medications, commonly used to treat hypertension and other medical conditions in the United States. And so we embarked on a study with the primary objective of looking at the impact of ASIs in patients with metastatic renal cell carcinoma. So we basically conducted a pooled retrospective analysis of clinical trials data, phase 1, or phase 2 and phase 3 trials sponsored by Pfizer between 2003 and 2013, and looked at the impact of ASIs in that population of patients. And what we actually found was, for the overall cohort of patients, that there was a statistically significant benefit in overall survival in patients who were treated with ASIs compared to those who did not receive ASI therapy. And this was statistically significant. Now, we did adjust for multiple factors, including age, race, disease risk status, the development of treatment-associated hypertension, the development of baseline hypertension, and even after those adjustments, we still found that there was a significant benefit to those who were on therapy with an ASI compared to not. Other key findings of the trial include that we did various sub-stratifications. We looked at patients who were only receiving antihypertensive therapy. We looked at patients who were receiving antihypertensive therapy who were also on VEGF-targeted therapy. We looked at patients who were receiving antihypertensive therapy who or were receiving VEGF-targeted therapy and developed treatment-associated hypertension. And in all of those subsets, there was a benefit to ASI use. Now, when we did do a sub-stratification based on type of MRCC therapy, whether it was VEGF-targeted, mTOR-targeted, or interferon-based, the benefit was actually only seen in the VEGF-targeted group, which suggests that there's a synergistic interaction given that both these agents work in the same pathway. And I think the implications of this trial are that though larger prospective studies are warranted to prospectively look at the answer to this question, in patients who warrant an antihypertensive or warrant essentially antihypertensive treatment, you may be wanting to reach for an ASI in that patient population, given that there may be the potential of a benefit in overall survival. A lot of patients who have kidney cancer have hypertension because of either a prior nephrectomy, and a lot of times the therapy that's associated with kidney cancer is one of the side effects is hypertension. And in those patients who don't have contraindications for ASIs, such as ACE inhibitors or angiotensin receptor blockers, you may be wanting to treat them with those drugs as opposed to using other agents such as a calcium channel blocker or beta blocker. And I think these are the practical implications for the clinician. When they're sitting there with their patient in front of them and their patient is hypertensive and they have kidney cancer, which drug to use? There's a plethora of drugs out there, and I think that if there is a potential for survival benefit with an ASI, you may want to reach for that medication. Like I said, I frame this all in the fact that this is a retrospective study. It's not a prospective study, but I think the data is very hypothesis generating and should be investigated. I think we need to look at this in a prospective manner. So taking patients who are on, a VEGF therapy with or without an ACE inhibitor or with or without a ARB, and see if the results that we saw in this retrospective studies do actually pan out in a prospective manner, and looking at toxicity that may be associated with the combination of these two drugs together in a prospective manner. I think immunotherapy is sort of where we're headed for this disease. In particular, a lot of the phase 1 data that's been published at various meetings have shown the potential for a long durable response associated with various immunotherapies that target the PD-1 pathway, and I think that there's a lot of hope there. The notion of a long durable remission, as close to a cure that you can get for somebody with metastatic disease, is something that we're all optimistic for. And I think there's other drugs in the pipeline. Cabozantinib is another one that's probably the next thing on the block in the world of kidney cancer. So we're optimistic. 5 years ago, now almost 10 years ago, I guess, we really had nothing to treat this disease, and now we have a plethora of treatment options with a lot down the pipeline, and so I think we're optimistic.